Hi, everybody. My name is Dr. Joshua Katz. I am doing this, as you can see, this isn't from my office. I'm going to introduce myself. I'm going to be talking today about how we do infusions at an infusion center during the coronavirus pandemic. So my name is Dr. Joshua Katz, and I am the co-director of the Elliott Lewis Center, and this is a center in Wellesley. It's a private MS center, and I'm getting a text, I think, from Sumaira, who I'm going to introduce in a second. I just want to make sure that this is technically working. Am I coming through? I'm looking for comments. So anyway, my name is Dr. Joshua Katz. Again, I work at the Elliott Lewis Center, and this is our team. We have a private MS center in Wellesley, and we see about 3,000 MS patients. And hold on one second. I apologize. I want to make sure that we're working here. I'm going to keep going in just 1 minute, and as soon as I'm sure that we're transmitting. It looks like we're on. Okay, so sorry about that. Yeah, so this is our team. We have an MS center where we treat roughly 3,000 MS patients and patients with NMO and anti-MOG antibody syndrome. My partner, Dr. Ellen Lottie, and I are here in this picture. You can see the rest of our team. And we have a private center that has an infusion clinic. We do research there. And we've had to contend with how to manage our patients during the pandemic, and it's been a bit of a challenge. Before I get into things, I want to thank the Sumaira Foundation and Viela Bio for putting this on. These series have been incredibly helpful. We've had so many patients really needing to have more information, and it's coming from all different places. If you didn't have a chance to see Dr. Michael Levy's talk that he did last week, I would really strongly encourage you to watch it. He gave a ton of useful information. I thought it was, even I learned a lot of things during that talk. And so I would encourage you to check that out. It's on the Sumaira Foundation website. An interesting story about how I met Sumaira. About 4 or 5 years ago, I was on an airplane, and in front of me, I heard somebody having a conversation, and they mentioned something about neuromyelitis optica. We had never met before, and we just struck up a conversation, and it turns out I'm a neurologist. Sumaira has neuromyelitis optica, and funny coincidence. And she said, well, she was going to be starting this foundation, all very interesting. In the meantime, I was busy moving our center out of St. Elizabeth's Hospital to our new location in Wellesley. And a couple of years go by, and it's turned into this enormous thing, and she's doing a fantastic job. I just can't believe what a dynamic and effective person she has been at starting this foundation. So great job, and it's really an honor and a privilege to be a part of the foundation, and I'm pleased to have an opportunity to talk to you today. Viela Bio, who is sponsoring this, are making, in the process of developing an NMO drug called enamelizumab, which is an anti-CD19 drug. It's similar in some ways to Rituxan and ocrelizumab, and we're hoping to see that come on the market soon. Okay, so I'm going to talk today about how we've been running our infusion clinic and how we've been able to manage to keep people on their disease-modifying therapy, both for MS and for neuromyelitis optica. And it's been a challenge. These are difficult times, right? This is a bit of a scary time for everybody. There are a lot of unknowns, and I think when we don't have a lot of answers, it's normal that we try and sort of grasp for answers. And so I'm going to tell you now, a lot of what we recommend to people are based on things that we're not 100% sure of. We don't know a ton about the interaction between COVID-19 and people with multiple sclerosis. We know even less about it with neuromyelitis optica. So I'm going to say a lot of things that I'm going to couch as speculation. So don't take what I'm saying as 100% accurate. This is just my best guess at how things are working out. We can't see your face. Oh, I forgot to switch back. Sorry about that. I was showing our center. I have to switch back and forth here. Okay, so one of the problems I think we're having is sort of knowing how to live our lives normally. And if you were recently diagnosed with neuromyelitis optica, not only do you have to contend with trying to figure out how you're going to work and get your treatments, but you're still dealing with the diagnosis. And I find that most people, when they're diagnosed, is a very difficult time for people. And for many people, it's traumatic, actually. Most people are fairly young and healthy, and having this new diagnosis is, in many cases, terrifying. And the problem is that there's a grieving process that we have to go through after you're diagnosed. Even if you're doing fine and you don't have any leftover symptoms, just adjusting to the diagnosis is very difficult. And now our lives are so disrupted by the pandemic and how much this has affected everything that it puts that grieving process on hold. And that means eventually things are going to get back to normal. And it might take 6 months, it might take a year, but then people are going to have that delayed grieving process. And I guess I'm thinking that that's going to be important for people to keep in mind, that psychologically this is difficult for everybody, but it's especially hard if you have a chronic illness and you've been recently diagnosed. All right. So again, there are no right answers here. I'm going to try my best later on to answer all of your questions. Keep in mind, we would like to have concrete answers to all of this and to know things for certain, but we don't, even under the best of circumstances. In any one individual, the answers are not always clear, and we try and tailor our answers to every specific patient. So there's no right answer for everybody, there's just the right answer for you. And the most important thing is, no matter what I say, no matter what information you hear from me, I'm going to recommend that you always check with your doctor first. Don't take my word for it. I think you want to check with them. So I'm not the authority, your doctor is the authority. And again, for more information about COVID-19 in general, I would encourage you to see Dr. Levy's talk from last week. It was absolutely spectacular. So let's see, what has it been? Maybe 6 or 8 weeks that this has been going on. I can't even keep track. So we have an infusion center where we have roughly 300 people who are on a medication Ocrevus, which is very much like Rituxan. Rituxan is one of the most common IV infusible drugs that is used to treat neuromyelitis optica. We have patients who are on that as well. It's generally given about every 6 months. Occasionally you'll see different dosing regimens, but most people are coming in for treatments every 6 months. And the question is it safe to continue getting your treatment? And how do you keep getting that safely when there is a pandemic and you don't want to be exposed to other people? So we've had to balance the risks to both our patients and our staff. And we've done this at every sort of weekly interval. I would say we keep updating what we're doing. So the very first thing that we did is we have 2 nurses who work at any one time at our infusion clinic. And I'll show you what our center looks like. So this is what our infusion room looks like. Now normally we have 7 chairs and room for an 8th patient in there with a wheelchair, which you can't see in the corner. And we have 2 nurses that work at once. And the first thing that we did is we started to stagger our nurses so that we only had 1 person in at any one time, so that if 1 person got sick, that wouldn't bring the whole center down. The other thing about our center is that unlike a hospital, we have a parking lot. You walk in the front door. I'm pointing with my pointer, which of course you can't see, but that is what our center looks like. You walk in the front door and you're immediately in the waiting room and right into the infusion clinic. And the clinical offices are separated from the infusion clinic so that there's very little contact. One of my concerns about people going to a hospital setting is that you have to run a gauntlet of potential exposures to coronavirus that comes from the parking lot, maybe door handles, elevators going all the way through to an infusion clinic. So I'm nervous about people going to a hospital setting, and I would always make sure you check with their infusion centers to make sure what their recommendations are about how to get in and out of their centers safely. So we are lucky in the sense that we have relatively little barriers between us and the infusion clinic. So simple things. One, I propped open the door so people don't have to touch the door handles. Now, what we have is we only occupy every other chair so that patients are always at least 6 feet apart. And now we're recommending that everybody wear masks, including our staff. Now, we don't have enough N95 masks to go around, just like a lot of other healthcare centers. So we're doing our best to try and budget them. So there are a lot of risks to think about if you're going in for treatment. And here are the things that we don't know. So one is what is your risk of going to the center itself and getting exposed to the virus? What about the risk of the medication? Some of the medications are what we call cell-depleting drugs, and they may weaken your immune system and make you more susceptible to getting the infection. They may make you more susceptible to having a severe infection. We don't know about that. What about some of the longer-term risks of being on medication? One potential problem with some of the cell-depleting medications is that they may reduce the effectiveness of vaccines in the future. These are all the risks on the things to consider on the side of what are the downsides of treatment. But I would have to agree with Dr. Levy that for the diagnosis of neuromyelitis optica, the risk of a relapse far outweighs any of those risks. We don't want people stopping their treatment because even, I would say, under the worst case scenario, which is that you get exposed to the virus and you actually get COVID-19, we don't know that the treatments actually will make your infections worse. In fact, there are some theories that being on any drug that reduces the activity of your immune system, at least in theory, might reduce your risk of having a severe infection. So we don't know, but we do know what the risk is of not being treated. On balance, again, we're not recommending that anybody stop their treatments at this time. So I'm trying to think of other things that we've done to reduce the risks if you come to our center. And one is we are always cleaning everything in between every infusion. We're keeping people 6 feet away. We're wearing masks, and we're making sure that people have minimal contact with any surfaces when they come and leave our center. And there are things that you can do if you're planning on getting an infusion. You really should think about planning ahead. One is try and get some kind of barrier. If you don't have a mask, even wearing a bandana or covering your mouth may help, maybe not so much to reduce your risk, but really what we want to do is reduce the risk of you infecting other people. And anything that's a barrier between your mouth and the outside environment has the potential to protect somebody else. Bring wipes with you, bring tissues with you. If you have to press an elevator button, it's better to have something like using a tissue or using a glove. If you're using a bathroom or a door handle, have something between your skin and that door handle if possible. Wipe your hands with hand sanitizer if you have it, or wash your hands, or I should say, and wash your hands thoroughly. Every time you are touching anything, you need to make sure that you're sanitizing your hands with hand sanitizer and washing your hands if possible. In theory, if you take all of these precautions and you are not exposed to somebody else and you're at least 6 feet away, your risk of getting exposed to the coronavirus should be very small. And when I think about what the risk is of being on medication, one of the problems is some medications like Rituxan we know do have a slight increased risk of respiratory tract infections. But if you look at the overall risk of getting the coronavirus, unfortunately, it's actually very high because it seems to be a very infectious virus. And even if you do have a slightly increased risk of being infected because you're on something like Rituxan, that increased risk, I would guess, is actually very small compared to the overall risk. And if you are following all of the recommended precautions and you minimize that risk, I don't think being on treatment is actually all that risky. And I'm going back to thinking about what the risks are of being on medication compared to stopping medication. Again, I think the risk of stopping medication, even in going to an infusion clinic where you may have an exposure, still far outweighs the risk of stopping medication. I'm not saying it clearly, but what I'm saying is I don't want you to stop medication. I'm going to take a moment now. I've been rattling on for a few minutes, so let me just see what kind of questions have come in. All right, so one question. If there are patients who generally get infused at Boston hospitals who have neurologists at these hospitals, can they go to your center during a pandemic for infusions? Do you know if there will be additional insurance issues? And so the short answer is we can take referrals to our clinic for infusions. And we're doing this on a temporary basis. As long as we have contact with your physician and they tell us what the issues are with you coming here, we are able to transfer some patients to our center. I'm trying to think if there are any real insurance issues doing that, and I'd say most of the time, no. I mean, most insurances, if you're getting treated at one place, you can transfer over, but we do end up having to run authorizations beforehand and make sure that we can get the drug at our location without you getting an enormous bill. So we basically will run the authorization just to be sure, but most insurances have actually been accommodating. So the short answer is yes, we do have the ability to take patients at our center. I'm going to qualify that by saying we have to make sure that we can schedule it because we are getting busy. But the short answer is yes. Let me see if I have any other questions. I think that's all that's come in so far. Here's another one, actually. So I go to a busy hospital setting at my infusion center, and because there are a lot of people that have coughs or may be sick from their oncology treatments, how is it best to manage their exposure to other patients, especially if they refuse to wear a mask? How do we know what they are sick from? Well, yeah, that's a very good question, and I think that honestly would make me a little bit uncomfortable. At most centers like that, for patients' own benefits, they should be wearing masks, especially at hematology oncology centers. You have patients who are potentially severely immunosuppressed, and they really should be wearing masks. And I think at this point it is now the government's recommendation that we all wear masks when we're in public spaces, so that should be enforced by the infusion center. And I don't think there is any way to know what people have. And the best practice, and this is what we're doing at our office, is you treat everybody, whether or not they have symptoms, as though they have COVID-19. And unfortunately, we know that people can have it and have absolutely no symptoms and may actually be infectious. So the best practice is treat every single person like they are infected. And if you are at a center where you can't stay 6 feet away, you don't have a mask, and you think you're going to be exposed to another human being, regardless of whether you know they have it or not, I would say that that isn't a good situation. Okay, here's another question. Is the usual blood work, lymphocyte subset panel, CBC, CMP, I'm not quite sure what that is it necessary to get before each infusion? That means I would need to go before the infusion a week or so. Well, I'll tell you what we're doing at our center, which is that we draw people's blood at every infusion, but not beforehand. Now, this is really particular to B-cell depleting drugs, that our expectation is that most people, if you're being treated every 6 months, your B-cell count is frequently 0 at the time of the infusion. We don't wait for it to go up. So I don't know that I really need to check your white blood cell count before that unless you have a history of your B cells coming back early. In that case, we might want to check them a month beforehand. And then that introduces another potential problem, which is that if you have to go to a lab, that's another potential exposure. Now, I understand that a number of labs are actually making arrangements to have almost like a drive-through ability so that you're not getting exposed when you get your blood drawn. And in that case, I don't think it makes any difference. But for me, there aren't lab tests that I need to do before I feel it's okay to infuse you in most cases. But that's going to depend on what your doctor thinks. Okay, here's another question. If I get 2 doses of Rituxan, should I only get 1 dose now? So I can tell you what I've been doing, which is that after a few years of treatment, when people have been, if their B cell counts are 0 at each infusion, I have felt comfortable transitioning people to 1 gram every 6 months. And that doesn't mean that's the right thing to do, because I don't think we actually know the answer to that. And then it would come down to a question about what your doctor thinks. And I think partly that depends on how active your disease was in the past and how long you've been on Rituxan to decide whether or not you could go to 1 gram every 6 months. And it's a good question. And I think the potential advantage is that you're going to obviously reduce the number of times you're in an infusion clinic. So good question. I don't have an answer for you specifically, but it's an excellent question. Does Soliris affect my immune system and ability to fight the virus? As far as we know, Soliris should not, and in fact it's being investigated as something that might actually be helpful for people if they get the coronavirus infection. If you actually get infected with it, one of the theories about why some people get very ill with the coronavirus is that they get something called a cytokine storm, and that they have so much inflammation in their body that the inflammation actually does more damage than the infection itself. Soliris, because it blocks something called complement, and complement is a very important mediator of inflammation. By blocking complement, theoretically, you could actually reduce inflammation. We don't know this for sure, but if anything, I wouldn't be worried about Soliris weakening your immune system. I think it might actually potentially be helpful. The interesting thing about Soliris is that it does increase your susceptibility to certain types of bacterial infections that require complement, but not to viral infections. So I think Soliris should be safe. All right. Ooh, I can tell this is going to be a tough one. I am currently 37 weeks pregnant. My last Rituxan infusion was in October 2018, and I was planning to restart after my delivery. Would this be too much of a risk for myself or to my baby? Okay, well, I am assuming that your diagnosis is neuromyelitis optica. And what we know about neuromyelitis optica is that unlike multiple sclerosis, which becomes typically less active during pregnancy, neuromyelitis optica does not necessarily. It can continue to cause relapses right through pregnancy. And in some cases, we'll actually treat people with Rituxan straight through pregnancy. And while it isn't 100% safe, if you look at pregnancy registries with women who have been pregnant on Rituxan, the risks are, I would say, in some cases, acceptable. I don't want to speak to how you and your physician have negotiated this, but in some cases I would be willing to treat people with Rituxan straight through pregnancy, depending on the risks. Then the risk after delivery. At that point, I think it would be safe to resume treatment as early as possible after delivery. The only issue would be breastfeeding. And we think that fairly small amounts of Rituxan are expressed in breast milk. So some people actually think that it may be safe to continue to give somebody Rituxan and breastfeed. My feeling about it is that I'm not sure, and I would probably prefer for somebody to forego breastfeeding rather than getting a distracting text right in the middle of my answer. I apologize. But generally, I recommend for any antibody type drugs that people don't breastfeed unless they absolutely feel it's necessary. So let's see, 6 months ago, I had my first 2 Rituxan infusions without incident. And what are your views on having the next Rituxan infusions at home? Well, that's an excellent question. And generally, okay, so there are 2 things. I think if everything went perfectly smoothly, in theory, it should be okay. But there are a couple of reasons why I actually don't like people getting infusions at home. Now, I'll talk about this in the without a coronavirus pandemic, and then what we would do in the present right now. So, assuming there is no coronavirus pandemic, I very much prefer people to get infused in my clinic for a couple of reasons. One is that as the prescribing physician, if anything happens, I'm on the hook for it. And I really don't like the idea of somebody having an infusion reaction and my not being there to see them through it and to take responsibility for whatever happens. So as a practical matter, I just feel a lot more comfortable when people are at my clinic. The other thing is that I really appreciate the opportunity to stop in and see how people are doing while they get their infusions. It's a good opportunity usually to combine that with an appointment. So just for practicality, I find it helpful. Another practical issue is that every time that I've tried to give medication at home, I find that the nurses who administer the medication at home some of them are excellent, some of them are not as good as our nurses, so you can have trouble putting in the IV. And invariably, I find I get a lot of phone calls, well, somebody's blood pressure went up or somebody's blood pressure went down, or they're getting a little bit of chest tightness. Many of the times that we try and give this at home, people just aren't quite as comfortable with it, and it causes problems. I've had cases where somebody has stopped the infusion and left because they said, oh, the person had a reaction, and before I could even have an opportunity to discuss it with them, they've canceled the infusion. So those are the potential hazards of getting infused at home. In general, I find that it just doesn't work as well. Now, what about during the pandemic? I would say it's up to, of course, you and your doctor to discuss it. I think there would be circumstances where I'd consider it. And I guess the reason I'm having problems with this is that I still think our clinic, where there's a fairly limited exposure to other people, I think the risk of coming to our clinic I've likened to the risk of going to a supermarket, and probably a fair bit safer actually. So I think if you're coming to a small clinic, the risk of exposure is very low. And then if you're going to a hospital versus home infusion, that's a toughie. I'm not sure. Talk to your doctor about it, but certainly worth considering. I have a reputation, I'm going to tell you now, of giving extremely long answers to extremely short questions. I will try not to do that, but we still have plenty of time. So let's see. All right. Is there a high risk factor for a patient on Rituxan to contract the virus than a patient on Cellcept? Well, nobody really knows the answer to that, and I think both medications have the potential to increase your susceptibility to respiratory tract infections. I would have a hard time comparing those two drugs and saying which one would put you at higher risk for contracting the virus. I think I could make an argument. See, I don't want to speculate too much. I was going to say that perhaps the risk of a more serious infection maybe would be on Cellcept, but I actually don't think that's true. My experience with both Cellcept and Rituxan is if I look at people who have had other types of viral infections, if you look at, for instance, the flu or any other type of upper respiratory tract infection, my experience is that those infections tend not to be any worse than they would be in the general population when people are on Rituxan or Cellcept. So at least that's been my experience so far, but the truth is we just don't have any data yet to know whether or not those medications will actually make an infection more severe or not. Okay, here is a comment. I currently take hydroxychloroquine for rheumatoid arthritis. I think I need a drink of water. Do you have any opinion about its relationship to COVID-19? So hydroxychloroquine is the drug that our president has said is very promising. And when you look at the studies, there have been a number of small studies done in China where they have given people with mild infections hydroxychloroquine, and they believe that it may lessen the severity of infections. I tend to be very cautious about interpreting small studies with very small numbers because it turns out these would be the equivalent of like a phase 1 or phase 2 clinical trial. And so I've been involved in a lot of clinical trials where you've seen early data make something look promising. And then when you do much larger trials, it turns out that positive effect actually goes away. And I think honestly, it's just too premature to say whether or not hydroxychloroquine is going to have any beneficial effect. And we know that it certainly can have side effects, that at high doses there's a risk for seizures and other things. So, not sure. I think given how severe this pandemic is and how we're all scrambling to try and come up with some kind of solutions, I understand why there is great enthusiasm for things and why we want this to work and we want it to be effective. But the short answer is I think it's too early to say for sure. I would side with Dr. Fauci on this one, that I want to see more data before I make any recommendations. So potential promise there, but we will have to see. Is there anything we can do to make us stronger to fight off the virus if we are exposed? Vitamins, supplements, anything that makes our lungs stronger, exercises? Well, that's a good question. I think anything that you can do that may have a potential benefit to your immune system is relatively small benefit compared to all the precautions you should take. I think the number one thing that you can do is make sure that you do every possible thing to reduce your risk of infections, and that will have a much bigger impact than any potential positive benefit for things like vitamins. I think there's been some indication that perhaps vitamin C might reduce one's risk of getting an infection, but I'd say similar to hydroxychloroquine, I am skeptical as to whether or not that's true, and whether or not exercising increases your ability to fight off the infection. In general, I think any time that you are fit and in good shape, you are going to do better with any medical condition. So by exercising, you're improving your cardiovascular performance. You are probably not necessarily going to reduce the risk of getting the infection, but I do think that if you're in good physical shape, you are much more likely to tolerate having an infection. And for instance, let's say you did get severely ill and you are on a ventilator. That is an enormous cardiovascular stress. And if you're in good shape and you exercise and your lungs are in good condition beforehand, you're going to have a much better chance of surviving that and doing better. So there certainly is an indirect benefit to exercise, but whether or not that would actually reduce your risk of getting an infection, I don't know, and I suspect probably not. So let's see. What are your thoughts about medications such as Actrema and the coronavirus? Oh, IL-6 medications such as Actrema. Well, actually, so the other name for Actrema is tocilizumab. That's actually being studied as something that may potentially reduce inflammation if you have the coronavirus. So they're looking at that in clinical trials to see whether that actually might improve outcomes. Again, too early to say. Based on how that medication works, by blocking an inflammatory mediator by IL-6, I don't see any reason why that should make you more susceptible to a coronavirus infection. And again, at least theoretically, it might actually be helpful rather than hurt. So I'm hopeful that that will be something that we'll see as a potential treatment, but it's going to be a while before we know that. My daughter had her only 2 rituximab infusions near college. She's home now, and we need to find a new place. What questions should we be asking about any hospital infusion center in our selection process? Excellent question. So the first thing is you want to check with your physician to find out where they use, and I think you're better off going to a private infusion center rather than a big hospital, just because you're going to reduce your risk of exposure going to a smaller place than a larger place. You certainly want to know if they have experience giving Rituxan. And I would think it would be better to have a place that's supervised by physicians than not, although as long as it's not the first infusion, as long as they have nurses there and they know how to deal with infusion reactions, that should be fine. And then you have to make sure that they're accepting your insurance and that they have the ability to authorize your insurance there. I mean, we have somebody whose job it is, their sole job is just to work with insurance companies to make sure that we get things authorized so that people don't get stuck with a big bill. So you want to make sure that they have the ability to do that. Here's a comment that says, "Thank you. You're welcome. It's fun to do. Once I get over the initial anxiety of being live, this is actually quite enjoyable." So what about the New York City testing? I see that is from somebody named David. You are going to have to clarify that question, so I don't know what you mean. What about the New York City testing? So ask that question again and clarify it, and then I can try and answer it. All right, here's another question. I'm doing an online search for infusion centers, resulted in a number of oncology offices. Is it common for infusions to be performed there? What would you view the relative risk for getting an infusion at an oncologist office versus an infusion center? I'm assuming hospital is the worst. Yeah, I'd have to agree that, maybe the single biggest risk factor for an infusion center is going to be its size and what what the entry is to get in and get out of there. You also have to think about transportation to these places. If you're taking public transportation, that's going to be another big issue. So you want to be able to drive there and get in and out relatively easily. I think going to some place where they treat a lot of oncology patients, at least in theory, those places should be extra sensitive to the risk of infections because they're dealing with immunosuppressed patients. So that should be fine. So in general, I would say size and having experience giving Rituxan is probably the single most important deciding factor. Small and lots of experience. All right. Does prednisone have any benefit in dealing with the virus as an anti-inflammatory? Maybe, we don't know yet. So the problem with prednisone is that it's a pretty blunt instrument. It is a very good anti-inflammatory medication, but it also does weaken the immune system to some significant degree. So we see the risk of infections is actually higher when people are on steroids like prednisone. And people can get things like shingles a little bit more frequently. So that, I think we don't know the answer to that. I think if you had a severe infection and let's say you were on a ventilator and you had a lot of lung inflammation, at that point you already have an infection. At least theoretically, I could see that prednisone might be helpful, but I think prior to that, it probably increases your risk of actually contracting the virus somewhat. But like pretty much everything else that I've been answering, I'm going to admit that I don't know the answer to that. I just don't know about prednisone. And I think if you have to be on it, you want to check with your physician and see what their opinion is. So I think I've actually caught up with the number of questions. So I'll have to think about something else that I can say while I'm waiting for more questions to come in. Let's see. I'm going to go through my notes, see if there's anything else to mention. If we talk about the different treatments that are available for neuromyelitis optica, the one that I use most frequently is Rituxan. And when you look at how effective that is, some of the newer medications like Soliris are actually even more effective at suppressing relapses from neuromyelitis optica. But the problem with Soliris is that it's given every 2 weeks. And if you're not getting your infusions at home, then there's a potential risk of exposure there. My experience with Rituxan has been very positive, and I actually haven't had a patient break through on that yet. So I tend to use that medication first. Something else just came in. So have you ever come across an NMO patient who has had a cell count as high as 82 B cells before their next Rituxan infusion without a relapse? Yeah, actually, we are looking at this with a similar drug, ocrelizumab, which is approved to treat multiple sclerosis. Is another B-cell depleting drug that's very similar to Rituxan. And we've seen patients whose B-cell counts actually are normal at the time of their infusions. And theoretically, that should track with the risk for relapse in multiple sclerosis, although it doesn't necessarily. But in neuromyelitis optica, I think the association is pretty good. So in other words, when we see people's B-cell counts come back in neuromyelitis optica, I get very concerned about their risk for relapse, and I would consider treating somebody earlier. I don't usually do that with MS, but with neuromyelitis optica, I would. So if you're at a 6-month mark and you have your B-cells starting to return, I'd probably start checking it at 3 months and then check it monthly. And at that point, when your B cells started to come back, that's when I would dose you with your next infusion rather than wait for the B cells to come up, because we know that at that point you are at risk for a relapse, or at least that's what appears to be the case. So for NMO, I would be concerned if your B cells are coming back. People are wishing me to stay safe, which I really appreciate, and I am doing my best. Is it okay to do MRIs right now? Well, a lot of centers have actually stopped taking orders for routine MRIs, and I think it's like anything else. You're going to a center where you may be exposed to other people, and if they're not wiping down the machinery, there might be some risk of contracting coronavirus just through contact. The nice thing, I don't want to phrase it that way, one interesting thing about neuromyelitis optica is that you tend not to see progression on the MRIs in between relapses. In multiple sclerosis, it's actually fairly common for people to have their MRI show new lesions when they are actually feeling fine. And for multiple sclerosis, I think it's very important to do regular MRIs for that reason. That tends not to be true for neuromyelitis optica. So I think the risk of having something new on your MRI without having symptoms is actually fairly small. It's a long way of saying, I would say right now, if you have NMO and you're due for a regular MRI, you might want to ask your doctor if it's absolutely necessary, and you may want to skip it right now. Even for MS, I think if people are stable right now, I'm suggesting they hold off, because pretty much any time you venture outside of your home, you're putting yourself at some risk. All right, here's another question. I always take pre-meds before my infusion. Tylenol, Benadryl, IV Solumedrol. Oh, it just jumped down, so I missed it. Sorry, I lost my place, so I'll catch up to this in 1 second. I take Tylenol, Benadryl, and IV Solumedrol. Should I not take the Solumedrol? I think it depends on the dose. I think a single dose of Solumedrol is not going to increase your risk of getting infected all that much. And I think if you've been on Rituxan for a long time, and I'm assuming those sound like pre-meds for rituximab, if you've been on that for a while, you might be able to tolerate getting the infusions without having a significant infusion reaction. With most cell-depleting drugs, when you get them the first time, the risk of an infusion reaction is much higher because you're killing off a larger number of cells, and then in subsequent infusions, often we'll measure your B cell count, it's going to be 0, and your risk of having an infusion reaction is much lower. So you could skip the Solumedrol. That's a question to ask your doctor. I haven't been stopping people's Solumedrol infusions because I think the risk of what that's going to do in terms of the risk of making a more severe infection or getting exposed is relatively low. So that I haven't been stopping people's Solumedrol, but not unreasonable to ask about it. All right, where am I? Have I heard of any Actrema shortages? No. Short answer is I'm not aware of any medication shortages as of yet. I think all of the supply lines that I'm aware of have been up and running, and I haven't been worried about that happening, at least not yet. You talked about your experience with Rituxan and NMO. What have you been seeing as to the effectiveness of Rituxan for MOG patients versus NMO? So MOG, in case you don't know what that is, it's a relatively newer diagnosis. So there are people who get optic neuritis and spinal cord lesions, and when you do a test for neuromyelitis optica, they test negative. And I'd say in the last couple of years, we found that some of those people have another antibody called MOG, or myelin oligodendrocyte glycoprotein, and it is similar to NMO and MS, but it's different. And the treatment seems to be different. So there have been some reports that Rituxan might not actually be as effective for MOG as for neuromyelitis optica. I have actually a number of MOG patients who are on Rituxan, and they've actually been doing fine. But I just had somebody last week who was newly diagnosed with MOG, and I'm going to be starting them on Cellcept, which is an oral medication, because that is supposed to be very effective, and you can avoid having to come to an infusion clinic with that. So my experience so far with Rituxan and MOG has been good, but I haven't had a ton of experience with people breaking through it yet, so we'll have to see. All right, where are we? What interleukin-6 levels in NMO and COVID-19 this is sort of a question about whether or not having COVID-19 could increase the risk of an attack. I would think yes. I think any type of inflammatory disorder can increase the risk of a relapse to some extent, both for MS and for neuromyelitis optica, but we don't know that, and I couldn't tell you how much. And of course, it's not something you have much of a choice about. So the main concern if you have COVID-19 right now is going to be COVID-19 and not the risk of a relapse, but it may increase your risk. What are the chances of a patient who contracted neuromyelitis optica spectrum disorder as a result of papillary thyroid carcinoma, which has since been removed, and only tested positive for NMO within the tumor, still having NMO for life? This is currently my situation. Hold on, I have to click down because it goes on. At the moment, my last Rituxan infusion was last March, so my doctors are waiting to see what happens at the moment because of a lack of data of what to do with regard to my rare case. So let me see if I can figure my way through this one. This is a tough question. They only tested positive for NMO cells within the tumor is the part of this that's confusing me, because I'm not sure how you test positive for NMO cells. What you test positive for are the aquaform pore antibodies, and what we know with NMO is that you can have a negative titer but still be at risk for a relapse. It's never really clear to me when I can stop therapy safely for NMO, and at the moment I don't have a way of judging that, which is a bit of a frustration. That's a little bit true for multiple sclerosis as well. We don't really have a good way of deciding when people are safe to come off of therapy. So I'm afraid I can't really answer that question, and I would say it is safer to stay on treatment, in my view, but I'm going to plead a little bit of ignorance on that one. Any speculations about Advil, Motrin, and Tylenol as being bad for COVID-19 symptoms? If so, why? I think that there were early reports that ibuprofen might worsen the infections. My understanding is, as of now, that's proven not to be the case. It's a relatively mild anti-inflammatory, and I haven't heard any reliable data that suggests that actually that does make your severity of the infection worse. I haven't heard anything at all about Tylenol. In fact, that does tend to lower your fever. I would think just for symptom management it would be fine. So as far as I know, those things are still safe, and I have to do a little bit more research to see if ibuprofen, if there's been anything more definitive about that. But the last thing I heard was that no, that doesn't actually increase the risk. I'm NMO negative and waiting on my MOG test. So it's not, I'm trying to think if I can turn that into a question. Often those come back together. So I guess one question that I would have is, where did you get the NMO test and MOG test done? We are usually sending those to Mayo Clinic because they do a cell-based assay. And there are other labs that don't do the same kind of test, and it's not as accurate. And usually those come back together. So I'm turning this into a question about where should you get your tests for NMO and MOG, and I recommend that you get them through Mayo Clinic because they do the most accurate cell-based assay, and some of the other labs may not be as accurate. I have a fair number of people who come back and they're negative for both NMO and MOG, and we call that antibody negative neuromyelitis optica. And some of those patients, well, we know that medications like Soliris, that was only studied for people who were antibody positive. We don't really know what that drug does for people who are antibody negative. Some of the other drugs that are being developed are actually looking at people who are antibody negative. And it interestingly seems that being antibody positive has a slightly better prognosis. My relative who has NMO anti-MOG had an MRI and it showed a silent stroke, but we could not definitively get to the cause after extensive tests. Possible reason was getting an IVIG infusion, as there is something, hold on, I have to click on this, something seen on a previous brain MRI, as there was something seen on a previous brain MRI. They're on max doses of CellCept for 3 years. In January, this is a complicated question, so bear with me. In January 2020, a neurologist scheduled a repeat MRI for this April with a follow-up office visit. Do you think we should keep appointments? Yes. Complicated question. I don't want to preempt anybody else's medical decision. If they think that they made you an appointment, I would say yes. This is complicated. I guess the one thing that I would think of here is that IVIG does have some small independent risk for stroke. IVIG is a very concentrated amount of protein, and in some cases can increase the risk of blood clotting. It's rare, but it does happen. So there is some small risk of stroke with IVIG. So I guess I'm sort of circumventing the bigger part of that question. Aside from doing a Google search, how else can I definitively identify nearby infusion center options? Doctors tend to want to send you to their hospitals. Is there some type of national directory due to licensing or other requirements I could access or locate, or a website that lists all licensed facilities? That's a tough one. So I think for certain medications, for multiple sclerosis like Tysabri, there have to be sites have to have something called a touch certification, and you can get all the listing of those sites. So one possibility would be to look at the Biogen website for places that do Tysabri infusions, and that will give you at least a list of sites that probably have some familiarity treating both MS and neuromyelitis optica. So that might be a starting point that is a little bit more specific than just doing a Google search. And it is true, most physicians, and myself included, are going to want to keep you within a certain healthcare system if possible, because then you have access to all the records. But you could always start by asking your physician if you can get a hold of them and see if they have any recommendations. But I guess the only other thing I can think of is that suggestion of trying to look at Biogen as though you were going to take the drug Tysabri, to see just if those infusion clinics would be able to offer you the treatment with the drug you're looking for. I am rounding the corner on 1 o'clock already, so we are getting down to the end of the questions here. Ooh, I think I actually did get to the end of the questions. Let me scroll up and see if I've missed anything. Somebody had mentioned that there's a list of sites that may be on the National MS Society page. That's from Lisa Ann Tarnowski. Thank you for that. That's a good suggestion. I think I saw another question pop up. The newest research on double seronegative NMO, and how do you see the difference between double seronegative NMO and neurosarcoidosis isolated to the CNS? Well, I'm going to tell you I am not up on the most recent research on double seronegative NMO. I think of neurosarcoidosis as being something that can mimic neuromyelitis optica, but that's something where I make the diagnosis by doing either a chest x-ray or chest CT to look for swollen lymph nodes in and around your lungs, which is the most common place that you see other non-neurological manifestations of neurosarcoidosis. The pattern on an MRI of neurosarcoidosis is often subtly different than what you would see with NMO, and though you can't always tell the difference 100%, it does usually look different. So again, since I'm running out of questions, I have a little more time to get into this in more detail than you probably want to know, but Neurosarcoidosis is often meningeal based, and you see inflammation in the meninges as well as in the spinal cord, and that's not the case with neuromyelitis optica. What else? Okay, so this is sort of a repeat. Will Rituxan put me at increased risk for COVID-19? So in general, Rituxan does have an increased risk of upper respiratory tract infections, but the increased risk of getting COVID-19 from Rituxan, I think, is so small compared to the overall risk. And as long as you're following the appropriate precautions, I don't think Rituxan should increase your risk of getting COVID-19 all that much. And again, the best thing you can do is to follow all the necessary precautions. Somebody mentioned that the Elliott Lewis Center, which is my center, has that we're an infusion clinic. I hope if you've been watching this, you already know that we do have our own infusion clinic. I don't want to spend too much time plugging my own center here. Let's see, what else have we got? I've got 5 more minutes. Oh, I should mention, by the way, if it isn't incredibly obvious by now, that I'm not giving this talk from my clinic. I'm at home today. And the reason, well, in general, while it would be a good idea to not spend too much time in the clinic, I have been going in every day and following the appropriate precautions, but I'm doing this from home just because I think my internet connection is more reliable and better, and I have the ability to put up pictures here, like of our team, which I can't do at the office. So that's the reason that I'm doing this from home. Can taking vitamin C or other things that are said to boost our immune system cause us to relapse? Well, that's a really good question, and I think part of the problem is that our conception of our immune system is a little bit oversimplified. So it's not just a light switch that you turn on and off or turn up or down. There are regulatory parts of the immune system that actually reduce autoimmunity. If you were to boost those parts of the immune system, you would actually reduce the risk of a relapse. So the immune system isn't just something you turn up or down, and that's part of the problem with the supplements that claim to be able to boost immune function. Well, maybe the biggest problem is that there's very little evidence that any of those supplements actually do much of anything. But even if they did boost immune function, the question is, well, what immune function are you boosting? Are you boosting the part of the immune system that fights off infections, or are you boosting the immune system that actually regulates the other immune system and would reduce autoimmunity? And the answer is nobody really knows. So I think when it comes to supplements, I tend to be rather skeptical of them doing anything to the immune system at all that's predictable. I do IVIG because of low IgG levels, and are you at higher risk for COVID-19? No, I think if you have, it's called hypogammaglobulinemia, if you have a low IgG level, you definitely want to boost those levels to reduce your risk of infection. Now, IVIG won't contain antibodies that will protect you from COVID-19 because most of us don't have any antibodies to COVID-19, to the coronavirus yet, but it is being studied. We're looking at people who have been infected with coronavirus, and those people will make antibodies, or at least some of them will make antibodies. And an experiment is being done to see if giving people serum from people who have been infected, if that can reduce the seriousness of infection because they'll have antibodies to COVID-19. Let's see, I have recently been told that I have NMO and have a C2 to C7 lesion. What is my prognosis long term? Can stress cause a flare-up? Well, prognosis in NMO, I think, has a lot to do with how well you recover. I've seen people with massive spinal cord lesions actually recover and have almost no residual symptoms. So sometimes people don't recover at all from relapses, but sometimes people make a spectacular recovery, and that's probably the single most important predictor of your prognosis. And can stress cause a flare-up? I think stress isn't good for any medical condition that I'm aware of, and I think stress does sometimes both weaken the immune system and sometimes can trigger inflammation for some people. But the problem is there's very little useful that you can do about that. I think we should all be trying to reduce stress if at all possible. And the idea that if I get stressed out, I'm going to cause more harm to myself, all that does is actually increase your stress. So there's really not much you can do with that information. Okay, I think I have time for one 10-second question. Oh no, I clicked over to 1 o'clock. I don't, and that's okay because I'm out of questions. So anyway, thanks for watching, and everybody stay safe, stay healthy, keep following those precautions, and take care.